Thank you. I hope you can hear me. So let me start by thanking the new chair and the organisers for inviting me to this timely and important discussion. I really look forward to the discussions. I've enjoyed the ones I've listened to so far. So let me start. Just waiting for my slides to respond. So I wanted to start by just framing the talk in terms of the most likely types of pandemic. And I've used the framework here, which has been made famous or infamous by Donald Rumsfeld, talking about known knowns, known unknowns, unknown knowns, and unknown unknowns. So the known knowns, clearly COVID-19. We know about it. We know it's currently causing a pandemic. I would put to you that actually we are also in the midst of a more insidious, but ultimately potentially more damaging pandemic, and that is the pandemic of antimicrobial resistance. Another growing threat which could result in a pandemic is that of vaccine hesitancy. In terms of known unknowns, we have pandemic influenza, in as much as we know that it can cause pandemics, we just don't know when it's going to occur. And then we have the unknown knowns, which are typically zoonoses or vector-borne diseases, of which Zika was a good example. These are diseases we know about, but we don't yet recognize that they have the potential to cause pandemics. And then last of all, we have the unknown unknowns, the killer virus from Mars, which is so beloved of some of our media outlets. But perhaps we don't have to look as far as Mars for the unknown unknowns. And the reason I mention these is because whilst for example, COVID, pandemic influenza, and dealing with the threat of vaccine hesitancy, clearly these response and preparation for such pandemics is primarily an issue related to health policy. But if we look at antimicrobial resistance, we look at potential pandemics caused by zoonoses or vector-borne diseases, then actually it's not only health policy that's important that can have an impact. It is agricultural policy, it is environmental policy that can also have an impact. So I just want to keep that in our mind, that health policy is not of itself the only thing we need to consider in terms of how we can actually effectively impact on pandemics. So this slide shows you what I see as the key elements of policy that are important for pandemic prevention, response, control. Health policy must include an element of pandemic planning. Pandemic planning will often be specific to different types of threats. So all countries in the world will have a influenza pandemic plan, but we need to consider the response to other emerging or potentially emerging threats. Looking at issues such as stockpiling of specific pharmaceutical and non-pharmaceutical products to deal with the most likely causes of pandemics. But of course, pandemic response, probably 90% of pandemic response, 80 to 90% of that response in terms of health is related to basic health infrastructure, both clinical infrastructure, service infrastructure, and public health infrastructure. And probably this is the most important aspect of health policy in terms of impact on pandemics. It's the policy that ensures that we have a health systems infrastructure that's able to respond. It's able to respond in terms of diagnostic capacity and competence. It's able to respond in terms of treatment services and capacity of those treatment services. It's able to respond in terms of public health activities such as contact tracing, and it's able to respond in terms of having the information systems that we need in order to track pandemics and understand them in real time. Remembering that we're often dealing with situations that we've never faced before, and there is a desperately important need for information on the fly, so to speak. I'm really pleased to hear in the last presentation the mention of the importance of public health engagement, or in fact that actually that got the top vote. This is an area which I think we're growing to realise is such an important part of health policy in terms of pandemic preparedness. I will come back to that in a little while. And then last but not least, in terms of the pre-pandemic phase, is health policy as it relates to research and innovation. Again, I'm going to come back to that, particularly when we think about things like antimicrobial resistance. But if we also look at the current COVID response, one of the things that we have struggled with since the outset is despite influenza pandemics, pandemics of other respiratory infectious diseases, as we went into this pandemic, still the evidence base on the relative effectiveness of different non-pharmaceutical interventions, whether they be physical distancing, the use of face masks, was unclear. The evidence base was weak. Now that is fortunately growing with time, but really research and innovation are crucial to ensuring pandemic response. And I see that as part of health policy. Now, during the pandemic, we need to ensure that our health policy ensures not only ensures that we can respond appropriately. I'll come back to the issue of appropriate response, but just to make the point here, again, giving the broader context of this summit, that one of the things we need is rapid, as I mentioned before, rapid flow of information. We need pipelines that will provide the information we need to make decisions. But not only that, but we need to have a priori have identified the triggers, what information will result in a change in the way we respond. And I'll talk about that in a little while. Health communication, of course, we need to have clear policy on who will communicate, how to communicate, what channels will be used. The world is very different from when I started out in infectious disease epidemiology and response and control in the UK. Social media was something that we'd never known about, but now channels like that become increasingly important. And pandemics, by their very definition, are global. And effective and efficient response to pandemics also needs to be global. And so it's really important that we look not only at national health policy, but as our chair said, international health policy, if we're to be effective in responding to pandemics. And then finally, in terms of health policy, we've looked at health policy in the pre-pandemic phase, health policy as it relates to the acute response, and then in the post-pandemic phase, our health policy needs to recognize the need to modify our preparedness plans, modify our response plans in the light of what we've learned from ongoing pandemics. And so if we put, apologies, there's a slight delay when I press the button, but in essence, the areas that, the ways in which health policy impacts on pandemics is in terms of prepare, respond, and reflect. Now, I'd like to just go into a bit more detail on some of these points in the next few slides. Preparedness, the cost of not doing it. You see here some slides from the World Economic Forum, from the Guardian newspaper, from the WHO that really make the point that actually the cost of dealing with a pandemic is many times larger than the cost of actually potentially preventing it, or at least preparing for it better. And there is a huge tendency to discount heavily the potential future savings compared to the costs of the prevention activity or the activity required to prepare for those prevention activities. And I think that this COVID, in the COVID pandemic, we've seen the value of investing in both public health and clinical infrastructure. So the response in China, the speed with which once the full nature of COVID-19 had been recognized, the speed with which actually it was controlled within China, a large part of that was the ability, the capacity to rapidly mobilize a public health workforce to undertake contact tracing. that is a public health capacity that is not uniform across the world. And then if I look closer to my base, that's the Europe, the EU, then clearly, if we just take a couple of examples, Germany and Norway, their capacity to actually roll out and ramp up diagnostic testing at a faster pace than perhaps some other countries, I think was instrumental to their ability to actually rapidly control the rising tide of COVID cases. So again, that investment in ensuring they have laboratory capacity paid significant dividends in terms of their ability to save lives, reduce costs. And I think that whilst in many areas of the world or activity of industry, there's a just-in-time ethic. I think that in terms when we think about pandemics, just in time, particularly when we think about supplies of critical diagnostic reagents and we think of supplies of personal protective equipment, those supply lines might be disrupted, will be disrupted by pandemics. And so their just-in-time mentality does not work when we think about health policy, particularly in terms of prevention of pandemics. And I would argue that actually building surge capacity into our health and public health systems shouldn't be seen as a cost. It should be seen as an investment. And keeping to the theme of the cost of not doing it, but now thinking more about the issue of innovation and research. This is the World Bank's report. I'm sure many of you will have seen it, where they concluded that the annual reduction in global GDP caused by antimicrobial resistance could be at least as large as the losses provoked by 2008. And I think that given our experience with COVID, it's very easy to see how a major health pandemic can have devastating economic consequences. But they make the point that the cost impacts would be worse than in 2008. And if you look at the bottom of that statement, they also make the point that actually it will lead to greater inequalities across the globe. And we really need to think about how we can invest now to actually prevent things getting worse. There's the need for research into new antibiotics, but probably just as importantly, we need a new funding model. We need a new funding paradigm for antimicrobial development if we're actually to see an acceleration of the development. At the moment, the incentives for the pharmaceutical industry are not great, and we need to think about how we can overcome that. Keeping to the theme of health service infrastructure, resources, and laboratory capacity is critical for infectious disease response. We at ECDC undertake regular evaluations of laboratory capacity across the EU. I think it's really important that when we look at developing capacity in our health policies, there's no room for complacency. We need to continually assess, evaluate our capacities. I think a learning point for us here in 2019 and 2020 with COVID-19 is that whilst our repeated surveys have demonstrated that there's a high level of competence within microbiological laboratories within the EU, and that level of competence and capacity is growing. In the early days of the pandemic, we actually lacked capacity for testing, not because the competence wasn't there, but because the supply lines for reagents were compromised by the pandemic itself. And again, that comes back to we really need to think forwards, think about supply lines as part of health policy and pandemic planning. And another issue in terms of health service capacity and infrastructure, I've mentioned several times, but I think it's relevant in the context of this overall summit, is the need for information systems that can deliver high quality information rapidly without overly burdening those who are delivering frontline care. And for me, what that means is we really need to ramp up, we need to invest more in the development of systems that can harness the potential of electronic health records. I know that there are many countries in which that is already relatively well developed, but that's by no means true across the whole of the world. And I think there's still a long way to go in terms of improving our ability to collect data in real time. And certainly my experience from 2009 and the H1N1 pandemic in the UK, but the UK was not unique in this, is that we struggled in the first few months to really define how the severity of H1N1 because of the difficulty of capturing data from hospitals and intensive care units. That's one of the big lessons that was learned, and certainly things have improved remarkably since then, but I would argue that there's still more to be done. Moving on, public and community engagement. I hardly feel I need to say this given the audience vote, but there's a growing recognition of the importance of this. Pandemic response, and COVID is a graphic example of that. Pandemic response often requires that we ask of our citizens, of our fellow citizens, that they actually restrict their daily activities to an extreme event, and we must involve them in making those plans, in sharing with them why we would be likely to ask them to do that. And there's a growing evidence base on that. And again, the organisation I work for, the European Centre for Disease Prevention and Control, recently published some case studies into the value of community engagement in preparedness for emergency response, and provided some guidance on best practice on how to do that. Evidence-based flexibility. This slide's very busy. It's there more to remind me than for you to read, but these are quotes from two important evaluations. In the UK, Dame Deirdre Hine evaluated the UK's response to the 2009 influenza pandemic, and at the bottom a quote from Harvey Feinberg's report on the evaluation preparedness response, WHO's response to the same pandemic. And in both of these, the authors make the point that actually the response to the 2009 pandemic, making sure that the response was proportionate, that the impact of the response, the opportunity costs of response proportionate to the level of threat, was really hampered by, first of all, the lack of timely information on severity of disease. And then secondly, the fact that actually we didn't have clear triggers, a priori defined triggers, for actually when we would decide to upregulate or downregulate response. Clearly, a lot of lessons have been learned from that, but I think it just makes the point that health policy in pandemic situation, health policy needs to be flexible. It needs to have identified a priori what evidence it will need in order to make changes to the level of response. And of course, with COVID-19, we know from a number of modeling studies that have been published over the last few months that the matter of a week or two in when measures are applied can make an enormous difference to the size of the peak that we see, and ultimately the morbidity and mortality and cost associated with a pandemic. And as I mentioned before, it's not just national policy. Much of what I've been talking about, the responsibilities there are national responsibilities, but we need good international health policy. The WHO has a key role in this and has been leading the way for us on COVID. I'm sure we've all heard the oft repeated phrase that infections do not respect borders. And I think perhaps we've heard it so often that it's a danger that we become indifferent through familiarity to that phrase, but it remains just as important as when it was first termed. And certainly in the EU, the European Commission has been working closely with the governments of the member states of the EU in developing joint procurement arrangements so that actually the EU member states can work together in joint procurement for medical countermeasures. And there should be another part to this slide. Yeah. And in fact, the European Commission has also created the first ever EU stockpile of medical equipment for dealing with medical emergencies, including pandemic response. And then last but not least, I mentioned the need to learn from pandemics and to shape or reshape policy in the light of those lessons. And I've referred to both of these reviews, but I think they were both excellently written and well thought through evaluations of the 2009 influenza pandemic response. The one on the left you see is the report by Deirdre Hine on the UK response, and the one on the right is the cover page from the evaluation led by Harvey Feinberg into WHO's response. And important lessons have been learned from that, and I'm sure that we will continue to learn. And so turning now to my last slide, just to remind you, these are what I see as key elements of health policy that impact on pandemics, and the impact that following, including those elements and thinking about those elements, is that ultimately it will save costs, that actually investing in preparedness now will save significant costs in the future. Investing now will reduce disruption on other health services, on life in the future. Public engagement will secure trust in the population, which is clearly important in sustaining the level and the depth of intervention that continues to be required with COVID. Of course, saving lives, that's the big goal of health policy here, and it's just as important in pandemics as anywhere else. Good health communication can reduce fear in the population. Good preparedness plans, investment in research and innovation can help to reduce inequalities. Learning from the past, hopefully we will actually improve our ability to prevent future pandemics, and ultimately all of this will reduce pandemic impact in so many ways. And with that, I would like to thank you for listening. Thank you again, the organisers, for inviting me, and welcome to, I look forward to joining the discussion after the next presentation. Thank you.